look at the cost of treating cancer, it runs into tens of millions. But if you can just adjust your lifestyle, your choices, you discover that your risk for getting cancer is low. The real cause of cancer isn't known, but there are risk factors that predispose one to having cancers. And these risk factors are 99% of all cases of cervical cancer that have been tested in the lab histologically, they found a particular virus there. HIV in the past, when it came, we had the issue of denial. People would say it's a white man's disease. Forget about them, nothing like that. Over time, the HIV advanced in their body system into full-blown AIDS. I've worked in rural areas and I've done typhoid surgeries 2-3 per night.
What do you mean typhoid surgeries?
Typhoid is a very serious disease.
Okay.
When typhoid comes, it eats you up. It eats up the intestine. It can make a hole there, especially in children. As a public health physician, I would say that immunization is the most cost-effective intervention of the century. As a matter of fact, as a house officer, you must take that legendary 72 hours call. So that means you start on Friday, throughout Saturday, throughout Sunday, and you hand over on Monday. And handing over means you're going to present a report of all that happened. So that was one of the times I cried. I lost 7 patients.
7 patients?
Yes.
Within your 72 hours?
Yes.
Thank you for watching The Yellow Mic. My name is Kongs Shamaki. I'd like to invite you to help us reach 1,000 subscribers. We are striving to make this worth your time. Also, like this video and share it to your friends, and let me know what you think in the comment section. Dr. Nana Emeribe, you're welcome to the show.
Thank you.
Please, what do you do?
Okay, I do a number of things. First and foremost, I'm a wife and a mother. I'm a medical doctor. I'm a public health physician. I'm also the president of the female doctors in Plateau State, and I occupy some other positions. So that's what I do, basically.
So as the president of, is it the
Female
doctors
yes.
in Plateau State,
Yeah.
what is your role like? What do you do?
Okay, the name of our association is the Medical Women's Association of Nigeria, Plateau State branch, and we have a motto that says healing with the love of a mother. So we're basically concerned with the welfare of women and children, both boys and girls. So it starts from pregnancy, birth, adolescence, up to adulthood for women. So all our programs revolve around providing services, education, and support for women and children.
And this is spanning throughout the local governments of Plateau State?
Yes, we go to various local governments. Wherever there's a female doctor working in Plateau State, she represents us. So when we're having programs, sometimes we have them in clusters, and they also hold in those sites.
Do you have an idea of how many female doctors we have in Plateau State?
Okay. For those that work in government settings, yes, I know. There are 172 female doctors, whereas we have some working in private settings, NGOs, and other private facilities. But we're close to 200 female doctors on the plateau.
So I figure it's not every female doctor that's registered under your platform, right?
Yes, we say that once you're a female doctor, you're expected to be a member of the M1.
Yeah.
But at times personal choices, but we let them see the need because it's a non-governmental organization. We volunteer our services. So I think almost everybody wants to volunteer. So once they have that, to get their buy-in, they join us.
You mentioned healing through the
love
of the mother.
Yes.
What do you mean?
Women, we have the Midas touch. We also bring the extra to it.
Yeah.
Yes, so as doctors, we can see our patients and walk away. But as mothers, as women, there's this extra love we have. There's this intuition. I know my female colleagues, you see a child is dying, you're doing CPR, she's saying, no, I won't let go. No, I won't let go. So we provide counseling to the families. For me, if I lose a patient, if it's a child, the mother is crying, I cry with her. So I'm just there, I hug and I stay because I'm a mother. So we have that extra touch that generally medicine wouldn't give, because medicine is hectic, it's tedious. We have lots of patients to see. But as women, we pause and say, what else can we do? So that's...
I'm wondering, has it worked? I mean, your forum, I figured one of the things you would do is try to reinforce certain ethics and expectations.
Yeah.
What are some of those, and is it working?
Okay, let me just take us a step backward. This organization is not just for Plateau State, it's an international organization. That's
Oh,
the
wow.
Medical Women's International Association, and we're 109 years old or thereabouts. And the current international president is a Nigerian,
Wow.
Dr. Eleanor Nwadinobi.
That's globally.
Globally,
Okay.
yes. And then we have, at the country level, we have a national president, and we are present in 33 states out of the 37 states in Nigeria.
Wow.
Yes, so we are active as we speak. The whole country will be coming to Jos in January for our National Executive Council meeting. So we are actively working for 43 years in Nigeria.
43.
So, yes, and I would say it's been working because the medical women, we have a number of programs we commemorate annually. So we usually go with the World Health Days that are mostly focused on women and children. As it is, I'm just coming from a school health program day at Guratop. Yes, throughout last month was the breast cancer month. We were all over the place. We're still going to Rukuba Barracks for that. In fact, we do so many things. We do so many things. The World Contraceptive Day. So we actually go engage media platforms, both social and traditional and mass media. And then we also have in our clinics where we work, the antenatal clinic, immunization clinics, we get to educate mothers over and over. So I would say, yes, it's been working.
Dr. Nana, how did you become a doctor? Sort of walk me through that journey.
Okay. I became a doctor in the year 2007.
Okay.
However, in secondary school, I loved economics so much.
Wow.
I was in the sciences, but I was very good at English. So I just felt, okay, probably I could work in a bank or be an economist. Then that was the period that computers were booming. I said, I wanted to be a computer scientist. But my dad, being a teacher, said, no, you must be a doctor. I didn't want that. I didn't want medicine. I just felt medicine was overhyped. So, but it was largely the influence of my dad. I didn't want to disappoint him or make him sad. So I went in and got admission to study medicine at the University of Jos. But looking back, I have no regrets because being a female medical doctor has given me a lot of platforms to be able to do the things I love, which is reaching out to people.
Yeah.
Yes, so that's how I became a doctor. And for my choice of being a public health physician, I love conferences, I love interactions, I love meeting new people. And I didn't like that monotony of going to the hospital setting every day and driving out. So being a clinician will restrict me to the four corners of the hospital. I didn't like it. But being a public health physician, conference this, research this tomorrow. So I just like the varieties that come with being a public health physician.
So who is a public health physician?
Okay. A public health physician is a qualified medical doctor that takes care of the health of the people at the level of the population. Anybody that walks into the hospital is a patient and will be seen on an individual basis.
Yeah.
So if I come with headache and fever, one doctor will see me based on that. But as a public health physician, we work with communities, we work with groups. So communities are not necessarily geographical locations, but also special groups. So what we do with them is we let them know that this health problem that you're seeing, it can be prevented. So we take them backwards to their lifestyle, their choices, their habits, different things, and tell them if you do ABC, this can be prevented. And as we know, prevention is better than cure. For instance, cancer, if you look at the cost of treating cancer, it runs into tens of millions. But if you can just adjust your lifestyle, your choices, you discover that your risk for getting cancer is low. So public health physicians will work at the population level. We are the policy makers amongst the doctors. We do the research and come with evidence and give the policy makers and say, based on research, it has been found that ABC is caused by this. So if you can make this compulsory, or if you can, institute this, you now discover that a lot of diseases will be averted. So that's what we do as public health physicians.
So talking about cancer, you mentioned there are certain lifestyle changes to reduce the risk of getting cancer. What are those lifestyle that needs to be checked? Yeah.
So let me start by saying that generally cancers, we say the real cause of cancer isn't known, but there are risk factors that predispose one to having cancers. And these risk factors are things either in the environment, on the person's body, either genetically or by virtue of his lifestyle that will endanger that person. But we have one exception to the rule, that's cervical cancer. I'll talk about that later. So those risk factors could be our lifestyle. For instance, consumption of processed foods, we know they are not healthy. They could lead to obesity. So obesity obesity itself can lead to cancer. Then eating those processed foods, because of the chemicals in them, they have free radicals, and these free radicals increase your risk. Smoking, nicotine is very dangerous. It causes so many diseases on virtually every organ system in the body. So smoking cigarettes, it's a risk factor. Alcohol consumption, sedentary lifestyle. We sit down on computers from morning till evening. We don't enter our vehicles. We just sleep. No exercise, no walking. So that sedentary lifestyle too isn't good. So when you have a diet that is poor in vegetables and poor in fruits, so those are things that will increase your risk. Why? Because fruits and vegetables have what we call antioxidants.
Yeah.
The free radicals are what cause cancer, things that cause cancer. So the free radicals could be found anywhere. Dusty environments, smoke and fumes from vehicles, the air from the AC, different things, processed food. So the free radicals tend to accumulate in our bodies. So when you take antioxidants, they displace them. So fruits are a very good way to do that. Vegetables, exercise. When you burn down calories and sweat, you are liberating the free radicals out of your body. So it's been said that when free radicals accumulate over time, then your risk for cancer becomes very high. So that's the little pathophysiology.
Yeah. So you spoke about cervical cancer
Yes.
being an exception.
Yes.
What is that?
Okay, cervical cancer is a cancer that occurs only in women, because the cervix is like the neck or the mouth of the uterus, the womb. So only women have wombs. So it's been found that over 90%, in fact 99% of all cases of cervical cancer that have been tested in the lab histologically, they found a particular virus there. That's the human papilloma virus. So because almost every sample taken has that virus, it's been concluded that human papilloma virus is the cause of cervical cancer.
Wow.
Probably you've heard earlier in the year where they were immunizing younger girls against HPV. So, and the HPV is sexually transmitted.
Yeah.
So the men are the ones that have it, but it does nothing to them. But when the man comes in contact with the woman, he drops the virus there. And because of the location of the cervix, and the virus thrives there over time with repeated exposure. So the vaccine is targeted at young girls that are not yet sexually active, so they can be protected. Peradventure, eventually start having sexual encounters, even if they come in contact with the HPV, they're already protected. So what the government is trying to do is to have a generation, starting from this year going forward, that are protected against cervical cancer. When they grow up in the next 10-20 years, it will no longer be a public health concern.
How do I prevent cervical cancer as a woman?
Okay, so as a woman, first and foremost, sexual hygiene, let me call it that.
Sexual hygiene.
Yes, first and foremost, the number of sexual partners you have should be minimal. So we encourage fidelity. If you have a partner, you stay with that partner. That's if you're married. And if you're not married, you use condoms. But the challenge with viruses is that they are so small, some of them can actually pass through the micro holes in the condom.
Even if it's not torn.
Even if it's not torn, they are so tiny. Some of them can actually pass. And then sometimes we only look at the semen, but sometimes some other sexual acts from the saliva, or if the woman has some sores around her genital areas, the virus can get there. So we just encourage either abstinence or you're faithful to your partner. Then secondly, women can check for this virus. There's HPV screening. A woman that's sexually active can check for the virus once in 10 years. If it's there, then measures can be taken. Alternatively, that woman can do a pap smear, whereby a sample is taken, a swab from her cervix, and then is now viewed under the microscope to see, are there changes? You see, cancers are chronic diseases to occur over a long time periods, 10 years, 20 years. So those screening and tests will help us detect them early so that treatment can be instituted.
A question I've always had in mind is, how do you explain a child born with cancer?
Okay. As I said, the majority of cancers, the cause isn't known. there are some risks. Some of the risks are genetic. So, for instance, for us women, they'll say if your mom or your aunt has had breast cancer, you're at risk. So, some of them run genetically in families. So, there are some cancers, again, that develop while the child is there. We could have some form of kidney cancers, brain tumors like that, that occur. And it still boils down to that interplay between the environment, the free radicals, the genetics. So anything can occur. I know newborn babies, from their mother's womb, as they're being born, they're taken straight to theater for surgeries to correct one or two of those conditions.
As a doctor, like a public health physician, what are some of the most prevalent diseases or sicknesses around Africa or Nigeria to begin with?
Okay. We could classify them either based on the group as risk or the type of the disease. So, for instance, for infectious diseases,
Yes.
we would say malaria is very prevalent in Africa because of our tropical climate. The mosquitoes thrive. They are resistant to the normal insecticides we use. They are resistant to the drugs we take to treat malaria. So, but when you look at children under 5, they're a peculiar group. And they are quite vulnerable because of their young age, their immature immune system. So they are at risk of coming down with so many diseases. So for children, the number one cause of the most prevalent disease among children or health condition would be pneumonia.
Pneumonia.
Yes, upper and respiratory tract infection. So either the upper respiratory tract or pneumonia, that means it has gotten to the lungs. So let's say respiratory tract infections, respiratory tract, where we breathe from our nose to our lungs, is the commonest. So that's why children commonly have flu. They are coughing, they have sore throat, they have mild fever here and there. Then secondly, we have, it could be malaria. We say malaria in children too. And then diarrheal diseases. So when a child purges. So those are the 3 common ones among children. When we look at non-communicable diseases, we have diabetes topping the charts. Type 2 diabetes. There are 2 types, 2 main types. There are different types. But we have the one that occurs before the age of 30. We have the one that occurs after the age of 30. So that's the one that is common. Type 2 diabetes mellitus. We have hypertension. And we have cardiovascular diseases. Yes. Other things that make your heart to enlarge or your pumps have issues. Then the 4th one, we'll say cancers. So for the non-communicable, so say diabetes, hypertension, other cardiovascular diseases, and then cancers in that order. Yes. So HIV/AIDS thankfully is no longer as prevalent as it has been, thanks to public health. There are innovations, there are medications.
Sensitization.
Yes, they are now saying there are jabs. You can take one jab that will last you a number of months before you come back. And then with the awareness, I think for HIV, awareness did the magic. And if you've seen anybody that's come down with full-blown AIDS, you'll be so scared and say, let me take precautions so I don't become like this person. Okay, so I think HIV is no longer a big public health issue.
But how bad was HIV in Nigeria, or is HIV? Because I know one of the biggest problems is data, gathering data, and how secretive we can get with data.
Okay, so HIV in the past, when it came, we had the issue of denial. I was in secondary school when HIV, in the 90s, it was coming up. People would say it's a white man's disease. Forget about them, nothing like that. But when people, over time, the HIV advanced in their body system into full-blown AIDS. And then you see them, they are so dry, they are passing watery stools, they had tuberculosis, so many issues like that. So that was actually a wake-up call for everybody, because you now discover almost in every other family, there's at least one person that has it. And because of the low level of awareness, that person has spread it to other people. So a number of people had HIV and they had AIDS. And then it came with lots of stigma because people believed that it was sexually transmitted and that is it. So once you have HIV or AIDS, you want to hide. Because even if you got it through blood transfusion or through any other means, people just assume you are promiscuous. So because of the stigma, people kept hiding and dying in silence. No matter what you ask them, they don't have HIV until they pass on. It was really an unfortunate situation. So awareness and sensitization really helped. And then destigmatization helped. In fact, some workplaces had, policies. If you discriminate this colleague because he had HIV or AIDS, you'll be sacked, something like that. Where because before then some offices wouldn't employ you if you're HIV positive. So I'm assuming I'm applying for the post of a computer analyst.
Yes.
My work isn't a risky job. And my HIV statistician determine whether I'm employed in your company or not. So the stigma was that bad. So, but over time, people understand. And then the absorption of those people that are HIV positive to become peer counselors. So when you go to a HIV center, almost everybody that is counseling you is also taking medications. So you actually feel at home. Oh, I'm not the only one. Look at how they are shiny and looking very healthy. Oh, so I can be like them. So that brought a lot of acceptance. And voluntarily, people will walk up and say, can I screen for HIV? And then I made it like compulsory. Once you're a pregnant woman, they get to screen you. Why? To protect your unborn child. So all these efforts over time has actually reduced the prevalence and increased awareness for HIV. And people don't see it as a big deal anymore. Yes. Instead, it was COVID-19 that everybody had issues with, but not HIV.
You know, COVID-19 was particularly interesting because of our experience with Ebola.
Yeah.
And we were not really sure how lethal COVID-19 was. If it was something like Ebola, then we would have all died. Exactly. So, yeah. But when people realized it was not like Ebola.
No. Luckily for us in Africa, other parts of the world suffered. But I think because of our repeated exposure to the flu virus, somebody has catarrh, we say, it will go after 2 days.
Yeah.
And for every flu infection you have, you develop some form of immunity against it.
For everyone.
They say there are over 1,000 variants of the flu virus.
Wow.
So so that means you don't have the same type of catarrh twice. That's what it means. So I want to believe that over time, and the problem is data. We don't do that research, so I can't say conclusively that is it. But I believe that I've had immunity for the different flu exposures. That's why COVID-19 didn't deal with us.
So what happens if your body becomes immune to, I guess, not just flu, but flu medication? Because I've repeatedly run into problems where I'm down with the flu, I treat the flu, but the next time that same medication doesn't really work for me. What's going on? Because
it's a different variant. There are so many, and they mutate so rapidly. They mutate because this global warming, our temperatures are warmer than they used to be. So the viruses too try to adapt, try to survive. So they keep changing and mutating. So if drug A was supposed to treat this particular one, because of the mutation it has, because the drugs go to target sites in our bodies and act, you discover that the receptor is no longer the same. It's not working. So that's what happens at that level. And so we have a big issue of resistance, especially with antimicrobial agents like antibiotics. This mutation is for both bacteria, viruses, and our people have this habit. My tummy is paining me, it's typhoid. They'll just go and say, give me this particular drug. And that drug's supposed to be taken maybe for 10 days, 3 times daily. But the person will take once a day for 3 days and throw the rest. So because of that incomplete treatment, the pathogen in the person's body, whether it's a virus or bacteria, develops some immunity to say, okay, this drug didn't knock me out, it becomes stronger. So that's why we're having a huge issue of drug resistance across board, including antimalarials. So there's a need for sensitization about drug misuse. Don't prescribe drugs for yourself. Meet a healthcare provider that has been trained to provide and to prescribe, and then take the medications as prescribed for that duration. It's very, very necessary.
Yeah. So I was going to take you to that malaria and typhoid problem that we have. Okay. Because it seems like 100%, or let me say 99% of our sicknesses, we often conclude that it's malaria and typhoid.
Yes.
Why do we, for instance, like I have patronized the primary healthcare unit. And the moment you come with complaints, the first screening is malaria and typhoid. And definitely, they always find traces of malaria and typhoid. And then they give you medication for that, and that's all. Is that a safe practice, or is there something, are we missing a bigger picture?
I think that's the predominant practice, not necessarily the best practice. Malaria, because it's prevalent. When you asked me, I said in Africa, I would say malaria is the commonest because of our tropical weather. So it's assumed that the first fever you present with, the first thing that's likely to be is malaria. But it's not necessarily so. As a public health physician, I work in rural areas and I try to sensitize people, and I tell them that not every fever is malaria, especially in a child. If a child comes to me with fever, I'll first of all look at the child's throat. It's likely to be a respiratory tract infection, tonsillitis. for a child. So, but the layman would think that my body is hot. It's malaria. That's one thing. So people overdiagnose malaria, even though they're not health professionals. That's one. Then secondly, the World Health Organization has made it a standard that because of how malaria has been abused in terms of the medications and the diagnosis, everybody that comes with a fever and you suspect malaria, that person should be tested with an RDT. That's a rapid diagnostic test kit. It's just take a microliter of blood or two drops of blood. In 10-15 minutes, it's going to read. If there's malaria, it will show. And that particular test strip, that cassette is very sensitive. If it tells you don't have malaria, you're almost certain you don't have malaria. But some people say, no, this is a symptom I'm used to feeling in my body. It has to be malaria. Apart from the RDT, we have the microscopy, which is a gold standard. And there's a technique to using the microscopy to check for malaria parasites. So I think malaria is overdiagnosed and we just abuse the drug.
Yeah.
So that's one thing. The worst is typhoid. People tell they have typhoid. I keep telling them, if you see typhoid, you not stay. I've worked in rural areas and I've done typhoid surgeries 2-3 per night.
What do you mean typhoid surgeries?
Typhoid is a very serious disease.
Okay.
I'll try and explain the symptoms to you. As a clinician, when someone has typhoid, he's likely to have a fever. That's not so high grade, but mostly in the evenings from 4 p.m. till late night. The person has a fever. The person is going to have headache. The person is going to have constipation, abdominal pain. And by constipation, you discover that for 3 days, you don't go to the loo. Then the next 3 days, you pass watery stools. Then it now stops and you feel unwell. That's a typical picture of typhoid. So as a clinician, if somebody presents, I ask the questions, and if they are pointing to typhoid, the test I'll ask the person to do is a stool microscopy. So these people shouting typhoid all around, how many of them have done stool microscopy for typhoid? Instead, they do this Widal test.
Yeah,
and Widal test is actually, I'm not just being blood, it's supposed to be a tighter test. In other words, for Widal test to be interpreted, the patient must test 4 times. So you come day one, you test, they take the titer. Come back after a week, you test, they take the titer. Like that, when you do it 4 times, and they now check from this one, if it's 1 over maybe 60 here or 1 over 80 here, has it increased by 4-fold by the time you did the last test? If no, then it's not typhoid. So it's an old test. It's not very efficient. We have more efficient tests. Typhoid is a bacteria. It's found in stool because it affects the gastro from the mouth. Yes. So if you check the person's stool, if salmonella is there, it's there. And it's very easy to pick up. Salmonella is very easy to pick up. So you could check typhoid in the blood, you can check in urine, but that of the stool is what is done mostly because the person that will come for typhoid must have been ill for at least a week. So it's expected by the 2nd week of that illness is in the stool. So now that I've explained this, not many people know this.
Yes.
They keep saying it's typhoid, and they keep abusing the little antibiotics that we're struggling to keep for treatment.
Yeah.
Ciprofloxacin is in trouble, and there's a lot of resistance there. And when typhoid comes, it eats you up. It eats up the intestine. It can make a hole there, especially in children. And once there's typhoid perforation, it's theater straight. So you see a child coming, or even an adult, the person cannot stand upright. We call it prostration. The person is bent. The tummy is just paining the person. If you examine, the tummy is stiff. In fact, you don't want to touch the tummy. So those are pointers. I will take them to theater. You now see where typhoid has eaten up the intestine. We cut it up and put it back together. So typhoid is a serious disease. So when they say typhoid, I just laugh. I say, you've not seen typhoid. Yes.
So, but what is it? If I go to the hospital today, and I'm sure if I run some blood tests, they're gonna say I have typhoid.
Okay.
There's hardly a single time I did blood test and they didn't say I
most likely is the Widal test they did for you.
Okay.
Yes, most likely. If you come to a center, a secondary health facility or a tertiary health facility like Juice, they are likely to ask for stool MCS.
Okay.
So that one, not just to look for parasites, ova of worms, but they'll think stuff. So if you next time ask them what test, they'll tell you it's Widal test, most likely. But the ideal test is the blood and stool MCS, stool microscopy.
So we pick up malaria from mosquitoes.
Yes.
Where do we pick up typhoid?
Okay, typhoid, as I said earlier, from our hands, from dirty hands.
Okay.
Poorly washed vegetables, flies when they perch from here to here, water that is unclean.
Yeah.
So these are the places that the bacteria thrives. That's why hand washing is the single most important thing you can do for yourself. It protects you against so many things. So my children, by the time they are 4 or 5 months, they start crawling. I start washing their hands because so now by the time they grow, they are used to hand washing.
Yeah.
You come into my house, wherever you are, from my husband to visitor, get warm water and soap, you wash your hand. Because you might wash your hand, but the people around you might not be doing that. So they also put you at risk of coming down with whatever. Our vegetables, we should wash them with lots of water and salt or vinegar, white vinegar. Once you do that, it removes the bacteria then. The reason why vegetables are a big problem, and for us on the plateau, we have lots of vegetables, people use human manure on them. It makes them grow very well.
Human?
Yes, they use human manure, human feces there. They mix it with soil and other things. So that's a form of manure for them. I remember that typhoid, that's salmonella, is being excreted in feces. So if somebody has salmonella and that fecal material is used as manure on the vegetable farm, if you don't wash it properly, so you see, you are infecting, you are getting yourself infected. So hand washing, washing of vegetables and fruits with salt or vinegar, keeping flies away from environment, and then also using clean water, drink clean water is very important. Not just water that is clean to your physical eye, but even microscopically to see that it doesn't have microorganisms inside. So those are the ways you can prevent typhoid.
Wow. As a doctor, have you ever cried?
So many times. I've cried for the practice of medicine. I've cried for my patients.
I know you say you cry with your patients,
Yes.
but when I say cry, I mean a condition or a situation that you felt was out of your control.
Yes, I have a few times. I've lost some patients that I felt they should survive. They should have survived. You know, you do the CPR, you get the blood, you give them all that, then all of a sudden you come and see an empty bed. It's even worse when the patient dies in your arms trying to resuscitate. It's very painful because it's a lot of effort you've put in. So at least let the patient survive. But they die. Also, my cancer patients, I've lost a number of them. It's very painful. And you see them in pain. Some would say, Doctor, I'm tired. But there's nothing I can do. Euthanasia is not approved and I wouldn't even go there. But it's like they're in so much pain, yet you can't help them, especially when the cancer has advanced and spread to the bones, to the brain, everywhere. You can't help them. So you're actually heartbroken over and over as a doctor, especially practicing in this part of the world. There are equipments, there are gadgets, there are technologies that could help this, but they are not readily available in our client. So you might know the technical, you know how to use them, but they're not available. When I go to rural areas, sometimes we use torchlights to take deliveries.
Wow.
We use torchlights to repair episiotomies. We use torchlights to do so many things. So if you're going for rural posting, you gather rechargeable for yourself and for your patients. And you see patients coming. In fact, it's rural posting is good, is an eye opener for we the healthcare, because we're at the tertiary centers here in town. We don't know what's happening, but people over there cannot even afford medications or their meals, and the setting is actually difficult.
Dr. Nana, I have met people who say immunization is evil.
Okay.
I know, like, there are reactions that children have to certain immunizations. Like, there are times when you immunize a child and the body becomes so hot. And you just have to watch them and cry with them and just feel like, okay, is this child going to survive? What is it? But overall, we have a lot of people who don't believe immunization is good. What do you think about that? Are there good sides and bad sides to immunization?
Okay. I would like to say that our people always believe that there's a hidden agenda, especially when the West introduces something.
Yes.
They'll say, they want to curb our population. No, they want to make us infertile. They want to do this and that, you know. So almost always see the COVID-19 vaccine, the controversies that came with it and all that. Look at the HPV vaccine. I don't know if you watch those videos.
Yeah.
They'll say, no, don't do that, don't do that. But as a public health physician, I would say that immunization is the most cost-effective intervention of the century, because immunization has the ability to save so many lives, of which we wouldn't have had the resources to treat them if they had come down with those diseases or probably have died from it. What is immunization? Immunization is a method of inoculating a pathogen or something that looks like a pathogen into the human body. The reason is that to stimulate the body of the person to build a little immunity.
Yes.
So that when the real disease comes, the soldiers are ready to fight back. So that's the whole concept of immunization. And there are different types of vaccines. Some are toxoids, some are live, some are killed. You'll be hearing all those grammars. So that's why some vaccines will make you feel feverish. Some you won't even feel anything.
Yeah.
Like tetanus for women, they will know. Any day to receive a tetanus shot, we're supposed to have 5 shots as women in our lifetimes. And there's a schedule for it. So most times when the women have tetanus, they run a fever for like 24 hours. You can't even lift the arm because it's a toxoid. Okay, yes. So like that and like that. So when we're growing up, you hear 6 killer diseases. You hear all those childhood killer diseases. Now you no longer hear things like that. Why? Because for almost every of those conditions, effective vaccines have been found.
Yeah.
For instance, you mentioned pneumonia there. Now we have the PCV that we give, the conjugate pneumococcal vaccine that we give. It protects against pneumonia. The BCG protects against tuberculosis. The measles like that. So over time, we take innovations, and we have effective vaccines. And as I said earlier, children are the vulnerable group. So we target them. So that if they can survive the first 5 years and get protected from these diseases, beyond 5 years, their body is strong enough to fight back. So immunizations are very, very good. It's there for our people to know that it's important, and they should ask questions. Yeah.
So back to polio and immunization.
Yeah.
There are people who have raised legitimate concerns where they say a particular community that received certain vaccinations and immunizations probably came down with certain ailment or deformity.
Yes.
I've heard of cases like in northern Nigeria, in Uganda, and some other countries.
Okay.
Is that not like a legitimate reason for people to be afraid of immunizations?
Okay. Let me take you to biostatistics.
Okay.
95% is what is the cutoff point that we use mostly. So, for instance, if there's an immunization, they'll say, okay, it's going to be effective and safe in up to 95% of all those that will take. So, it's 95% of the population is a large chunk. So, we have the outliers, the 2.5 here, the 2.5 here.
Yeah.
So, we have those outliers. So, vaccinations, would say they are very effective, but wouldn't say 100%. We can even give it a 99% effectiveness, but not 100. So, we can hear cases here and there of things that occur after taking certain medications or taking vaccines. When you look at the total people that took it, what percentage do those form? That doesn't mean their complaint is not valid or legitimate, but to tell you that because a small proportion has issues with it, then we're going to discard everything. It's like throwing the baby away with the bathwater.
Yeah.
Instead, more research should be done on these people. Why did they react in this certain way? Was the vaccine given to them, was it viable? Did it have issues? Was it a technique? Or there are some other environmental factors that predispose them to? So those ones become subject for research. And for those that have had it safe, they continue receiving. So it's actually a continuous process. However, there was a case in Kano, that's the Trovan, I think that's the name of it's not even a vaccine, I think it's a drug by, I think, Pfizer some years back.
Yeah, right.
They wanted to try, for every drug that has been manufactured or vaccine, it passes through stages of clinical trials. They first of all start with the rats, the mice in the lab, they scale up until then once they get to the humans and sites level, they test like 3 phase 1, phase 2, phase 3. So it's when it passes the 3rd stage, that's when they say, okay, we can now release in the market as a drug to be used or as a vaccine. So those people didn't test that. Instead, they now use the Kano population as their study, as their testing site without telling them. And a lot of children died, I think. So that's why the federal government sued. And I think they were compensated a few years ago, but lives have been lost. So this is actually a regulatory thing that companies, because they are very big, like the big farmers, like this, the giants, they should still adhere to study protocol because of the safety of human life. It cannot be replicated. Yes.
You spoke earlier about work ethics and you female doctors, your association, one of the cardinal points of your mission is for you guys as mothers to empathize with your patients. One of the biggest issues we've had, or I have even experienced personally in Nigerian hospitals, is lack of empathy. I'm not saying all, but to a very large extent, and I've heard testimonies from people who say, I went to the hospital and the doctors were not nice, they just left me. What is triggering Nigerian doctors and nurses to have that kind of perception, or let me say, behave in a certain way that the people detest?
Okay. So let me attempt going backwards. I think from our curriculum in the medical school, we do a little of social medicine, but I think it should be a huge part of our curriculum.
Yeah.
Communication. In communication, you find empathy. In communication, you find listening, because most people don't listen, active listening. So I think communication should be a major chunk of our curriculum from our first year in the medical school. So if you do that over the years, when you start practicing, it's already a part of you. You know the rudiments, the expectations, so it's going to help. Secondly, there's this doctor-patient ratio that the WHO has prescribed, and ours is very, very high. I'm not so sure now, but I think it's 1 doctor to 600 people in the community or the population. I think ours is 1 doctor, is it to 51,000 or so?
Oh, wow.
Yes, so we actually, the doctor-patient ratio, I'm not sure of the figures, but it's that wide. Yes, it's far from what the WHO has recommended. So because of that, doctors tend to be overworked. As a matter of fact, as a house officer, that's the first year of practice. Fresh from medical school, you do house job for 1 year before you serve NYSC. You must take that legendary 72 hours call. So that means you start on Friday, throughout Saturday, throughout Sunday, and you hand over on Monday. And handing over means you're going to present a report of all that happened. And if you can ask every doctor that's taking that 72-hour call, it's mostly in medicine posting, you lose patients. That was one of the times I cried. I lost 7 patients.
7 patients?
Yes.
Within your 72 hours?
Yes.
Wow.
If you have diabetes, there's some patients that if you cannot sit. If you have a diabetic patient on insulin, you have to test every hour. You have that one, preeclampsia, you have to give this, because some medications you chart them hour by hour and titrate them. You're exhausted mentally, and when you lose patients like that. Most of those patients were actually bad patients, so it wasn't mismanagement. But had it been there were 3-4 doctors, I wouldn't have said I lost up to 7 patients over the weekend. I would have said maybe just 1 or 2.
What do you mean by bad patients?
Okay, bad cases. Some cases are terminal. Okay. So you are just managing them palliatively, giving them pain relief, giving them just some form of medication just to keep them going, giving them oxygen. So those are very bad cases that when you check their parameters, they are actually poor. Like terminal kidney disease, liver disease, and all that, cancer patients. So it's not as if people that had good prognosis, of coming out of it. Yes, so that is so going back to it, that 72-hour call, you see, it's actually counterproductive, because every human being needs to rest within 24 hours.
Yeah.
So that long hours that we put into work as doctors actually makes us impatient. In fact, you have headache. Before you finish talking, they've already handed. I worked in Lagos State for 5 years in the government setting. As you are getting to office, you are seeing folders like this. So as you are seeing those patients, you are thinking of the traffic you drive back over Third Mainland Bridge back to your house. So before a patient finishes talking, okay, you just check, okay, renewal of drugs. So it's not because you want to work like that, but the patient that came expects to be seen that same day, and you, the doctor, apart from that, you're seeing those on admission, you're seeing those in emergency. So Nigerian doctors are overworked. So that might be, it's not an excuse, but that might be the reason for a lack of empathy. But as it is now, the Federal Ministry of Health, together with some other agencies, are trying to see that communication becomes an active part of clinical practice as we provide services. So I think hopefully in the nearest future, things would improve. I know doctors are leaving the country, nurses are leaving, so that even worsens. The strain on us is more when it comes to seeing patients. So that might be the reason, but not an excuse. We need to be nice at work, because we're dealing with human beings that have needs.
Yeah. How do we mitigate this problem of doctors leaving, the brain drain we're having? Because I look at it, I've thought about this thing, right? I know that doctors in advanced countries, or let me say first world countries, earn significantly higher wages. But the argument I always make is, we think of those doctors that earn in dollars and pounds and euros, and we quickly do the math and we convert it to our own.
Okay.
But those doctors do not spend in naira. They spend in dollars, euros, and pounds. They have to take care of their rent. They have to take care of a lot of other mortgage, utility bills here and there. They have to feed. They have to put their kids in school. A lot of things. Is it about wages, or is there something beyond wages?
Okay. There are multiple factors involved. I'm a doctor, so I can talk.
Yeah.
Most of my colleagues have gone. All my colleagues in Lagos, almost all of them they've left the shores of Nigeria. There are many reasons. And I would like to tell you that it's not about the income.
Okay.
A lot of doctors over there would prefer staying in Nigeria. Number one, the work environment.
Yeah.
I mentioned earlier the basic equipment and facilities you need to make your work very effective. A conducive working environment, we lack it. Yeah, you see doctors, like, we don't have, it's just one clinic, but different set of doctors use it every day of the week. We don't have our own space. I'll call doctor's office our own space. That's one. Another thing that I know has driven doctors away is career advancement. In other countries, other climes, as a doctor, you discover that you have the opportunity to go for this training abroad, do that one, and become highly equipped and highly skilled. Even abroad, Nigerian doctors, they say they're one of the best. In fact, our people live here and go over there and meet Nigerians to treat them, working in the yes, over there. So the thing is that career advancement, people want to develop in their line, in their chosen specialty, but we don't have the environment to encourage us to do that. And then insecurity over the years was one of the major problems. Once they hear a doctor, they will not kidnap you, they'll come and kidnap a member of your family. So maybe they think we earn 7 digits, I don't know.
Yes.
So in fact, as a matter of fact, there's a time that once you paint your house, you're in trouble. They'll come and kidnap someone in your house, thinking you have, or buy a car. So insecurity has made doctors to shy away from practicing in Nigeria. And then this is now I can bring the remuneration. So money is not at the top tree for doctors, because job satisfaction is very important. Okay, if a patient comes in with ABC, because of my skill and expertise, I should be able to attend to him and I see him walk out healthy. Okay, so those are some of the reasons I think. So to curb that, our work environment should be very conducive in terms of equipment, facilities, manpower, and then our career we should have a boost. Let me know that if I practice for 2-3 years, I should be able to upskill somewhere and then come back and practice as a better public health physician or as a clinician. And then the wages should actually go up because of the economy. Discover doctors cannot buy brand new cars. They don't even have their houses. And people say, aren't others working? We are working, but if you look at the number of years we've invested, I told you earlier, I've spent 14 years studying to become a consultant public health physician. So very few professions invest that number of years to get to the peak of their career. So I think a lot can be done. And Nigerians love Nigeria. If it can be safer, if it can be more conducive, it can be better, they'll rather come because they're really working hard over there. They're working very hard there.
Yeah. Let me take you back to medical school. Right. I don't know if you want to go there.
Sure.
What was your first experience in a cadaver?
Okay. At first, we were curious, we were excited. 100 level, you do all the basic sciences, chemistry, and the rest. So when we passed 100 level with our distinctions, we were all excited. Came to medical side with our whiteboard codes. They say anatomy. We're going for gross anatomy. That's gross anatomy. So we had So we filed out on the queue to go inside, and first of all, what hit me was the smell of formalin. Formalin is what they used to preserve them. It's very strong. It can make you dizzy instantly.
Wow.
It's just that over time, by the time we spent 2 years working with them, we got used to the formalin smell. But it's very strong. It's a preservative. That's what they used to embalm bodies. Yeah, so that's what they preserve them. I said, what kind of smell is that? Then it has an awful smell. What do you call that place? The cadaver room.
Yeah.
And I saw dried, caked bodies on metal slabs. I said, I was scared because they actually looked scary. And the person that took us, he was used to it. Hey, you, table this. So I open your Cunningham's manual and start dissecting. We said, wow. We were waiting for gloves. Which gloves? They said the formalin is a disinfectant, is a preservative, so we're not going to get any infection. So we have a dissecting kit, so you open and then you just start. So the Cunningham's manual, you read, they'll say make a 2 millimeter incision laterally. So nobody's there. They leave you there. So we actually teach ourselves how to dissect the cadavers from the skin to the bone. And every structure you need to know, because we do steeplechase. So the lecturer will just come and put, this needle of the syringe, say identify. What is the function? What is the this and this, to prove that, yes, this is this dissection and you know the part. So I was actually scared the first time. Some of my classmates fainted, but I was determined not to faint. But I would have been a candidate that had fainted.
Were there guys who fainted?
No, females.
Okay, more females.
Females, yeah.
Okay.
But what jilted me most was my first surgery. When I got to the clinical side, my first theater experience was nephrectomy. They were taking out someone's kidney.
Yeah. And
the blood and everything, I was so dizzy. I told you I was determined not to faint. So I just step out of the theater, get fresh air and come back. So that was it. And then the first childbirth, I watched a woman deliver. So those are the instances that I knew I almost passed out because they were unbelievable. In fact, they were mind-blowing experiences. But I got used to...
Did you think of quitting at any point?
No, I just told myself I need to be stronger, and then I didn't think
for your dad.
Yeah, exactly, for my daddy.
Is he still alive?
Yeah, he's still alive.
Okay. Is he very proud?
Yeah. I'm the youngest, so he calls me doctor. So he's very, very proud.
Yeah. So the medical school, 100 level, you do the basic sciences.
Yes.
What happens at 200, 300, 400, 500 level?
Okay. In the medical school, so we don't count 100 level as part of our medical school.
Okay.
We start from 200 level.
Okay.
And then we don't write exams every year.
Oh, okay.
So 200 and 300 is one academic year for us.
All right.
So then you do lots of things. So you write only one exam, and the exam is called the second MBBS exam. So all that you've learned over the past 2 years, you'll be tested, and you have the theory, you have the practicals, you have the viva. They teach us how to speak as doctors. So it's an oral exam where we are facing each other and they ask you questions. And they try to be objective. They'll say, okay, from question 1 to 20, pick a number. So you pick and you answer. So we do that viva. And then in medical school, let me just tell you, our written exams, we have multiple choice questions. Okay. So in other words, question 1 has options A to E. That's 5 options. Each option has a score of 1. If you fail, you don't get 0 in medical school. If you fail, you get a -1. You are penalized for failing as a doctor. And that's the training.
Wow.
You don't take chances with human lives. So medical school is very tough. So if you fail in other places, you get 0. Our own is -1.
Wow.
So if out of 50, you pass 30, and you failed 20, it's 30 minus 20. So for that test, you got 10 over 50.
Wow.
And nobody would... In fact, I know people that failed because of 0.05. Once they draw that line, they say it's medicine.
So it's either you pass or you fail?
Yes.
There's no in between?
No. If 0.5, even at postgraduate level, they won't. So they say they will not shift the goalpost. It's medicine, and we must be doctors. So medical school is quite tough. So when you pass the second MB at the end of a 300 level, lucky you now move to clinicals. So that's why I now see in the teaching hospital, you see some medical students.
Yes.
They are now in the clinical section. The preclinicals are in the university section. Okay. So when they now come over, they start joining the consultants for ward rounds. So that's where the apprenticeship starts. You go for ward rounds, you go for theater. In addition, you do your lectures, tutorials, and other things. So from 400 level to 600 level, you be an apprentice, you are learning, and you're being examined in every aspect. From pharmacology, we do a little of everything. We're not pharmacists, but we do pharmacology for a year. We learn the drugs, their formulations, how to prescribe them, We now do medicine and surgery, O&G, community medicine. We do pathology, ophthalmology. We do everything, psychiatry.
Yeah.
So that's why at the end of your 6th year, you become a doctor. You must have identified your area of interest. I would have been a gynecologist because it's very interesting.
Wow.
Women come, deliver baby, happy, those years, all those things.
Yeah.
But the work involved in O&G is so much. Most babies are being born at night.
Yes.
Emergencies come at night. You will run to a blood bank to go and get blood. You lose your patients. You do this and that. So it's quite hectic, but very interesting. Yeah. So from over the years, you develop your area of interest. So after that, you go for house job for 1 year, NYSC the following year. Then you write an exam called primaries in that area you've chosen. So if you've chosen ophthalmology, so you now write primaries in ophthalmology. If you pass, they can now come in for residency training for the next 6 to 7 years to be a consultant ophthalmologist. So that's how the process. So I wrote primaries in public health. I came in for residency, and luckily I passed all my exams. So now I'm done with training. I'm a consultant public health physician now.
Wow.
So that's how the journey is.
Wow. Wow. Is there any doctor you aspire to be like? I know as a filmmaker, I have role models that I look up to. Is it the same in the medical line?
Yes. There are many doctors I aspire to be like, but because I'm a public health physician, so people I want to be ought to be in my line. But apart from that, there are other doctors I admire a lot. So in my line of practice, we have very young female professors. Females inspire me a lot.
Yeah.
When I see a female that is older than me doing great things, number one, it encourages me that I can do it. Number two, it shows me that, wow, women are made of stuff. We are great,
Yeah.
Yes, we have the babies while we are studying medicine. We run the family, and then we actually advance in our career. So we have a number of them. There's this doctor in Port Harcourt. She's an ICT guru. She tells you she's a self-taught ICT guru. She's less than 50. She has an ICT firm. So we're having programs. She sets up the link for registration virtually, all the Zoom meetings and the connections, everything. She does everything herself. And she said that she learnt it herself. And she's a professor of public health. So those are people that I would like to be like them. People that are versatile, people that multitask, and yet deliver excellently on their task.
Yeah.
Yeah, those are.
Yeah. So in closing, I'm curious, as a public health physician, you sort of deal with like a general broad health condition of humans.
Yes.
Are there a list of tests that one needs to do, like a medical checkup that one needs to do primarily, maybe on a yearly basis or quarterly basis? What would be your recommendation?
Okay.
Yeah, for one to maintain optimal health.
Okay. Yeah, so it's good we check ourselves regularly. And it's been recommended that, in fact, once you're 40, they say life begins at 40. It actually begins at 40 because that's when your body starts to dwindle down. So it's as if you grow all up until you are 40. Then at 40, you start growing downwards, growing old. Yes. So 40 is actually a critical point in our lives. Like the men, they start having prostate issues. The females here and there, menopause around the corner. Yes. So I would say that annually, you're supposed to check your blood sugar at least once. And there are different types of tests you do. The fasting blood sugar, you do it in the morning before 10 o'clock, preferably before 8 o'clock in the morning. Then the random, you can do it any time of the day after eating. We also have some other tests for sugar, 2 hours postprandial and the rest. But basically, if you can do a fasting blood sugar at least once or twice a year, it will help you know if you have a risk for diabetes or not. Then your blood pressure checks, that should be done like every other month. Don't wait till the end of the year. Yes, like every other month. And it's quite accessible. Thank God for digital fix now. So even you don't need to be a doctor or health professional to be able to check your BP. So long as you follow the instruction on the pack and you're sure that it's a good product you have, you can check your BP.
And we have smartwatches now.
Yeah, we have smartwatches too. And some of the BP apparatus will tell you your BP is high, it's high normal, or it's low normal. See a doctor. Some of them actually they verbalize.
Yes,
so they let you know. They show you red color, green color, and yellow. There are some color codes to the BPs. Then in addition, you need to actually For the men, check your prostate. That's PSA. That's the name of the test you do.
Yeah.
It's the prostate and prostate specific antigen. It's actually a test that when you do, it lets you know whether you have a risk or not. Then for us, the women, we check our breast every month after our periods. Every month
after a period.
After a period. So like last month, my team and I were on the Just Metro bus. I don't know if you saw, with some guys, we gave them artificial breasts, and we took the Metro bus from terminals down to their last bus stop, and we came. Some went to Dong. About 13 of us did that, and we're creating awareness to commuters in transit. So we're teaching the women and the men. Tell your sisters.
Now this is regardless if you've given birth or not.
Yes, regardless. So you check your breasts, okay, every month, and then you do a pap smear at least once in 2 years. The pap smear is checking your cervix for risk of cervical cancer, and then generally you go to the doctor, check your urine too. You can see proteins or other things. So at least every year, preferably on your birthday, at least you remember it's your special day, you go to the hospital and do all those things. So those are, however, for occupations, there are specific occupations that need specific tests. If I'm getting a job as a driver, I should do my eye tests.
Yes.
If I'm going to work in a factory, and maybe a petrochemical company, I should have my baseline. So there are specific occupational tests. But what I've mentioned are the general tests.
Yes. Thank you so much. This is very eye-opening.
Okay.
I mean, no one would have really thought that public health is really, really that something that people need to listen to. I know you've gone to rural areas, you've been to nooks and crannies. Backstage, you were telling me how you had to go to places where you had to climb mountains.
Yes.
I am curious. In these rural areas, have you met quacks who are practicing?
Yes, I would. I meet two sets of people in rural areas. We have the quacks, and we have the traditional. Yes, yeah. And the people tend to believe in the traditional, either healers or the traditional birth attendants more than us. Why? Because of the issue of empathy. And then secondly, our culture. They'll say our forefathers used this and it worked for them.
Yes.
Why do you want to use the white man's own? So they actually have more trust in the people around them. Okay? Yes, so I've met quacks, somebody that probably has gone to School of Health Technology, and he will come and say he's a doctor, he'll wear his white coat and be selling medications. We don't have a problem with that, but the thing is that some medications are only given under prescription.
Yes.
Some drugs are not given concurrently together. Those are things we learn in pharmacology medical school. There's what we call polypharmacy. Do you know that patients are not supposed to take more than up to 5 drugs at a time? 5 different drugs.
Oh, really?
Yeah, it's called polypharmacy. It's wrong. So you see some, they'll up to 13, they'll now swallow. So those are things we try to cope.
I've taken up to 13.
Yes. So you're not supposed to take more than 5. You stagger it. Can it start with this set? As this one is improving. For instance, somebody comes with cough, catarrh, fever, this and this. Sometimes I'll just treat for malaria. As the person is improving from malaria, the cough is resolving, the catarrh is resolving. Those people treat symptoms. If you come with 10 symptoms, you get 1 drug for each symptom. But as doctors, we put the symptoms together, come up with 1 diagnosis, treat the main thing, and say, come back after 4 days, come back after 5 days. By then, most have resolved. Then whatever is left, we can prescribe. You see, that is rational drug use. So those are the things the thing we don't like them, but they're actually some intricacies to these things.
Yes.
And you can only get it in the training.
Yeah.
Yes.
Yeah. Thank you so much for your time.
You're welcome.
Really, I appreciate you creating time out of your busy schedule to talk to us today. And I hope you'll be back on the show.
Hi, you invite me. I'll come.
Yes.
Yes.
Yeah. I wish you all the best in
Thank
your
you so
endeavors.
much.
And I pray that God gives you more courage and strength.
Amen.
And I look forward to hearing about your mentorship program with other women.
Okay.
Yeah.
Thank you.
Thank you very much.
It's my pleasure.
Yeah.
Thank you.
Thank you for watching The Yellow Mic. My name is Kongs Shamaki. I'd like to invite you to help us reach 1,000 subscribers. We are striving to make this worth your time. Also, like this video and share it to your friends, and let me know what you think in the comment section.